Today it's obviously, a great pleasure and honor to introduce Ghassan Abou-Alfa from Memorial Sloan Kettering, where he serves as an attending physician and also a professor of medicine at Weill Medical School at Cornell University, and an adjunct professor in medical diplomacy at Trinity College Dublin. Ghassan completed his medical training at the American University in Beirut, did a postdoc in internal medicine, and trained obviously medical oncology and heme at Yale. And he also received an MBA from Columbia University and is currently completing his JD at Fordham University. Now, if all this is not enough, what he's really known for is that, he's one of the individuals who take drugs in their hands and conduct clinical trials, publish them in the New England Journal, and then they are being reviewed by the FDA and become standard of care. And this applies to all types of liver cancers. This applies to HCC in the first line, in the second line treatment. He is the lead author of the study that demonstrated the STRIDE regimen. He's also lead author for other TKIs, as well as has been very instrumental in leading in the field of cholangiocarcinoma and bringing drugs there into clinic. So it's a true honor to have him here. The very interesting part is, which I still don't understand 100% yet, what he started to do in the past number of years, where he actually became very interested in a more global approach. And as such, he has become the counsel of the governing board of the Asia Pacific Liver Cancer Expert Association. But not only this, he also is very interested in what is happening in Africa and is collaborating with Africa, because we all know that that is actually where the majority of cases of HCC occur. He has been recognized for his medical and humanitarian and social efforts by bestowal of the Order of Merit, Captain National Order of the Cedar. So without further ado, Ghassan, we are very eager to listen what you have to tell us.
Thank you so much, Tim, and good to see you all. Always a pleasure. I know I met many of you this morning. Of course, many of us know each other, but of course, look forward to meet the other colleagues this afternoon. And hopefully one day, as you know, I'll be at the NCI in 1 month as well. So hopefully we'll see more of you then. Thanks for all what you said, Tim. I can add on to that some updates since I sent it. So already I have my GAD. I got it as of September 1st. And also for the Asia Pacific, I'm now the Chief Scientific Officer for Apple as of the event that we just had in Honolulu. So nothing to be really kind of show off. This is really more teamwork, and very proud to really continue to work either with all of you or, of course, with all colleagues being hired in the US or internationally. Greatly honored and delighted to really join in, and thanks for the invitation again. I'm gonna talk about exactly what you referred to, which is in regard to what's going on specifically in Africa. And I kind of will give you those medical facts, and will probably explain why this change, or not add change per se, but add on a due perspective, and what are the rights and obligations. So with this, these are my disclosures, and this is really where my contacts are, and I put them in. I learned, this is how to contact. Actually, a little bit earlier, I was asked, how do you kind of like connect to everybody? And by all means, Aryan, now just put a QR code, let people reach out to you, let them talk to you. And of course, always we welcome any discussion or any point that anybody bring up. With this said, this agenda, we're going to look at what's the current status of liver cancer in Africa, how to build a Africa continental HCC guideline, and I'll talk why we're arguing on the continental part for the whole continent, i.e. We'll look into how to need for enhanced biological understanding of liver cancer in Africa, and why this is important, because this will hopefully enhance the access to care for patients with HCC in Africa. And of course, where do we go from there? So no doubt in regard to the current situation, that's really a paper that I give a lot of credit for Judeong Yang from now in Cedar Sinai in LA, that he published not that long ago, 5 years ago, and found that, as you can see, median survival varies quite a bit from almost a median that's not even met in Taiwan, all the way to, sadly, a median survival for patients with liver cancer in Africa of literally 3 months. And you can imagine all of us, what does that mean, especially in the setting of all the therapies that we have currently for the disease. And that's exactly the point, as Dr. Grattan just brought in, like, okay, proudly, we brought in drugs, they were approved by the agency, they're approved by other agencies in the world, but whom are we serving? And you can probably see that probably we're serving at most, if we really are so generous, you can say 15 to 20% of the patients in the world, and everybody else has no access to those therapies. That's why we have to pride ourselves what we do. We continue to do what we do, but you have to look a little bit in a broader perspective about how can we make sure what we're doing and proud of, how can we have it accessible to everybody. So enhance on unfortunate numbers like this one of median survival of 3 months for patients with liver cancer in Africa. So with this, one second, seems that the screen is not deciding to move on. Give me 1 sec. Here we go. So this, no doubt, certain efforts have been done to give credit, the NCCN, among others, but brought in what they call the harmonized guidelines. This one specifically addressing sub-Saharan Africa. To give credit, they have another one which is for North Africa and the Middle East. And in it, as you can see, they lined up all what's available and what's approved. But at the same time, you'll see that they kind of like faded away in a light gray, what's not available in Africa, and they just like highlighted in dark black the ones that are available in Africa. I would say this is genuine effort. We had a little bit of a kind of a question in regard to certain components, and we've been very vocal with NCCN about them, among which number one is who really was involved in this. And clearly, the presence of members of the medical expertise coming from Africa was there, but super limited, and really confined to like a couple of people, no more. And number two is, why are we splitting North and Sub-Saharan, even though we know that disease, unfortunately, is spread out through whole continent? And what about like trying to unionize rather than to try to kind of, binding in people in different directions? To be fair, their perspective is, you know what, we know Egypt is high presence of liver cancer, but they are of Arab descent, they are Semitic. That's why they will probably be more bound into the North Africa / Middle East. But on the other hand, we know very well that, Sudan and Egypt are kind of like, a transcending of all what's happening in Ethiopia and below. So definitely Egypt do understand that they have a presence in regard to Africa, and they're very keen on making sure that this relationship is highly celebrated and same time highly appreciated to make sure that they can do what's better for patients with liver cancer in Africa as well. So for that purpose, we went ahead and now that we have a little bit of limitation got to what NCCN has done, we kind of like back in 2016 was a meeting that give credit to Ashraf Omar, one of the hepatologists from University of Cairo. And we were in Chicago and we really brought up saying, how about we build a continental guideline for liver cancer in Africa, by Africa, for Africa? So we went ahead and as a first exercise, and I'm showing that data which already is published, but I'm showing it before even I talk about the whole study, only to bring the argument why. We asked one of the question in the query that we asked, and I'll talk about the query in details in a second, but we found actually to the contrary to what NCCN could have thought, that, yeah, of course, everybody knows about NCCN. Well, guess what? As you can see over here, even in the highest GDP areas in Africa, which is North and South Africa, 31% know about NCCN. In East and West, 28%, and in Central, 23%. And as you can see, with regard to guidelines, it's all over the place. Everybody will use their own different set of guidelines. Maybe you'll see a little bit more presence in regard to the Eastern European Association for Study of Liver because of the closeness of Africa to the European continent. On the other hand, you'll see that some other places, they have either a very rare use, but applicable liver cancer guideline, like, for example, the Japanese one. or also they built their own locally advanced, guidelines per se, because, after all, we cannot really understand which one to use, let alone that many of them did not even use any. So this at least was a good further supporting argument for us that we really need to do the work, see exactly how our colleagues in Africa do assess patients with liver cancer. What do they depend on to assess their needs and their necessities in regard to therapy and, of course, even to prevention? So with this, we built a whole committee, and this is probably a picture that encompasses the whole committee. I put in here Ashraf Omurma I spoke about already, but as you can see here, and I'd like to really celebrate all of them because they're really beyond superb colleagues that we continue to, believe it or not, still meet. We've been meeting through the pandemic since the start of the pandemic in 2020, and interestingly, even to yesterday, just yesterday, we had our follow-up meeting, and we proudly are very happy to see all of them coming from throughout Africa, literally from the Mauritius Island all the way to Ghana, and at the same time from Egypt all the way to South Africa, with clear also presence in Central Africa, where really there's a big problem with HCC. So we're very happy to have them all on board, and we already did the work together, and very proud that we have done so together. So what did we do? We actually had a very kind of basic component. And by the way, here's a challenge. You can understand that to connect with colleagues in Africa in regard to meetings is not really as straightforward as it is, because time zones differences, they are in work, sometimes power shortages, connectivity, but nonetheless, we were able to circumvent all of that. And over a year and a half, we met on a regular basis until we came down to the point of let's build some polling data that will be able to ask for the colleagues. We're going to invite everybody to a meeting where we're going to discuss all what we have information-wise, what's there, and we would like to know more. Just tell us about who you are, what do you do, and then we'll look at that data together. And as you can see, the questions were very basic. What's your specialty? How much liver cancer do you do? How do you screen? What kind of preventive therapy approach do you use? How do you stage? What are the curative therapies that are available to you? Intermediate therapy, systemic therapy, second line, or any other comments? As simple as that. This actually dissected in about 40 specific questions that were brought in to the colleagues that were invited to the meeting. No payment, totally free. Anybody who would like to come and join in, they are welcome to come. And interestingly, the meeting was actually devised in a way, and I'm giving only an example here. We had some didactic lectures that always were given by colleagues who are either expert on or really highly experienced with regard to the specific situation because of their presence with the disease. Regard to prevention, Lewis Roberts, whom you know from Mayo Clinic, talk about HBV. Ashraf Omar talk about HCV from Egypt. Vikash Sauram spoke about NASH from South Africa. Judong Yang, who brought up the first paper about prevention and vaccination from Cedars-Sinai, as we said. After that, we carried on. Now we divided. And this division was not really us. It was our colleagues in Africa who decided that based on GDP, we'll divide Africa to three places. The North and South, highest GDP, East and West second, and Central, as I mentioned. And for North and South, I like to kind of note their names. We have Wendy Spearman from South Africa, Ada Bunajjar from Algeria, and Nkosi Ndlovu from Zimbabwe, and Lewis Roberts again closed the dates for the first day. And we carried on the second day, and this time we looked to East-West. Ali Mikhail Desilgan from Ethiopia, Jaren Dumolo from Tanzania, Mary Fiheni from Ghana, and of course I gave to help out some reflection on the first components. Then we carried on, and this now we're in Central Africa. Ashraf Omar start kind of introduced to where we are. Christian Zeton from Cameroon, Precious Makonde from Malawi, Akwi Asombak from Zambia, again opened on the part of the Central Africa part. So as you see, this is like two works in the making, and we invited all entities to give credit. Actually, I believe Satish was representing CGH from the NCI. We invited NCCN, Al Benson was there, and we really were learning from each other. Now, the question is, how many people came to that meeting? Believe it or not, 500 people, or close to 500. So remember, I said 40 questions. You multiply 500 by 40, you get 20,000 data points. So clearly, we felt like we have some information that really is worth looking into further. So for that, we actually led to an analysis of the material. I here would like to really also quote two important people, Marinella Capano and Yulin Lee and Joan Chu, three people who really are the biostatistics force at Sloan Kettering, who did help analyze the data. And we came up with this paper, which is in JCO Global Oncology, looking to Africa guidelines for hepatocellular carcinoma, a build-up process. Build-up process because, of course, we knew very well we're not there yet. We know some data. I'm going to share the data with you, but we did acknowledge what are the limitations that we have so far. Very important point over here that the data that I'm going to show you, of course, is analyzed based on that GDP part, but give a lot of credit for Marilla Capano and Yulin Lee specifically, because they really brought in is a question from the Biostats part. Did we really ask everybody in Africa? Do we have a good representation? Is it only the physician who have access to internet and they knew about what we're doing that they really answered? Number two is in regard to access to care is really being, for example, from downtown Maputo, different from being somewhere in the remote areas of Mozambique. Who knows? So for that reason, we analyzed it with those limitations, and we found the following. So number one, we have to give credit, and I'm giving this as an example. We had a good sample size. The single sample size was represented, for example, Central Africa, which is a very difficult to access to, but as you can see, 14 countries are in Central Africa, and we had data from 8 of them. So we had a rather appropriate representation, not perfect, but appropriately adequate for the analysis. And if anything, we found many things that you can see over here. I'm going to show you the data in 2 variants. One of them here in regard to the hepatitis B and C and universal precautions and how much is it available or not. And you can see that people do rather well. I mean, contrary to some misperception that many of us would have in regard to how well Africa does in regard to the access to either prevention or precaution or vaccination, it rather do very well. And this is really what we pride ourselves on. And they were very happy to see that, yes, after all, the continent is doing better than anybody would have thought. Then, however, when we came to the numbers per se, to start on one more time, you can see here, for example, and now please, you can do always, you could look at north-south compared to east-west, compared to central, and of course, we have the rest of the world. Because at that time, we really invited some colleagues from all over the world, understandably only to get a sense about what's going on. And we kind of like really put this as a potential comparator per se. And as you can see the numbers, even in Central Africa, we have rather a very robust number. For example, look at this, 78% for Central Africa hepatitis B vaccination. In regard to, for example, East and West, we have, for example, 75% in regard to hepatitis B treatment. However, what really was a little bit relatively alarming to us is that in regard to hepatitis C treatment, and you know, this is mainly a Egypt problem, only 63% had access to care. This is despite all the superb effort that the government of Egypt is doing in that regard. The other thing we analyzed is how do you surveil? And we found that, yes, there is a certain use of search surveillance, but sadly it's rather limited. But nonetheless, it was standing out mainly for alpha-fetoprotein and ultrasound, which really something that we're very proud of. Actually, Shinwei was just talking about that a little bit earlier, that we noticed that in areas where there's like limited number of physicians, proudly they are very well trained. And mainly they are trained in Europe, because this is where really they go to. If they are from Francophone Africa, they will go to France. If they are from the Anglophone Africa, they will go to England, and they'll come back to really exert their experience. And clearly we see that they, yes, they do quite a bit of alpha-fetoprotein and ultrasound per se. Now, when it came to, however, the other components, number one is the diagnostics. You can see that, you know, in general, CAT scans drives through most, but not necessarily always. In regard to the staging classification, you will see that is relatively all over the place, but VCLC from Barcelona, which is literally right across from Algeria, has a lot of presence in regard to evaluations in Africa, with about 60% on the average. But intriguingly, we saw that even Okuda, because some doctors actually trained in Japan, they kind of like have some presence, especially in East-West Africa. And when it came to the NCCN guidelines, I showed you the data in the argument why we're doing that effort. We repeat it here in now verified data. And you can see here that the NCCN guidelines, at most, you can say, average about 20% of the physicians will have access or use the NCCN guidelines, while everybody else will use their own different perspectives as well. Now, when we come to the therapy, now we're starting to discover that, yes, there's a problem. And this is exactly why the argument for doing this. You discover over here that of the all 461 patients divided among the 3 regions of Africa and the rest of the world, you can see that resection remain present, especially in North, South, and East, West. At the same time, transplant is only limited to the North and South because only 2 transplant programs are in Egypt and in South Africa. On the other hand, you can see that other components of RFA, microwave ablation are there, but interestingly, alcohol injection, which still we use, but rarely, is still present about like 15% or so. And why people don't get this, you can see, and this is a very important number, access. 43% of the physicians in South Africa say, you know what, we can't even do that. So that's really people don't get the access they need for the therapy that they are in need for. When we come to intermediate stage, again, same story. Interestingly, though, we learned that actually Africa rather do well in regard to embolization. You can see that 72% north-south. Interestingly, even in South Africa, about 30% have access to that. Radiation therapy is relatively there, but limited. But remember, in general, oncologists in Africa are trained as oncologists/radiation oncologists. Interestingly, though, a lot of use of chemotherapy and immunotherapy. And if you ask why, because they said we have nothing else to use. But at the same time, prohibitive cost really drive, especially in East, West, and Central Africa as well. And then we come to the systemic therapy. And this really was an awakening. Please do remember, before I carry on, this data was done at the time. The only option of checkpoint inhibitors that was approved and used was atezolizumab plus bevacizumab, which is fair. It will give you at least a sense of what's going on. But if we focus on this, number one is, contrary to the misfact that we thought that, oh, sorafenib is easy, it's accessible, it's cheap, it's now actually even available generically. Well, in maybe North-South Africa, 80% have access to sorafenib. But look at this. In South Africa, only 50% of the patients have access to sorafenib. On the other hand, if you go on to the more novel, even though it is non-inferiority, but nonetheless, there's a certain preference for it nowadays, lenvatinib, it's really limited. Barely 9% in North-South and barely 2% in the East, West, and Central. And then we come to immunotherapy. Look at this. Barely 5% of our colleagues in Africa have access to immunotherapy or checkpoint inhibitors, which is really, it awakens you to how much really patients are behind radiotherapy. And please remember, Hep B drive most of the patients that they get liver cancer in Africa. And we know this is where probably everybody do benefit from checkpoint inhibitors, but Hep B patient will benefit the most. And without access, what's the survival? 3 months. And of course, you can use here even those efforts that were nobly done a long time ago by the NCI in Africa, among which talks use of doxorubicin. And then we know data from China about FOLFOX. Interestingly, they are even being used, even though the data is not robustly present for that purpose. And from there, you go into an endless mixed bag in regard to the second-line therapy, where really there's not a single reference to anything. Probably the one that stands out the most is 42% access to regorafenib in North and South Africa. But besides this, barely any therapy that's available for anybody. And of course, for first and second line, you can see that the prohibitive cost, limited access are the biggest problem that Africa does have a problem with. So for that, we kind of got that data. Yes, we're proud we published it, but we did acknowledge the following. Number one is, did we do it right? To be fair, it was more of a polling for a meeting. It was not really regimented the way it appropriately should be done. For that reason, we kind of decided that maybe we should repeat the exercise, but in a more appropriate way. Number two is we also pose the question, did we reach to everybody? Exactly as I just mentioned, and Dr. Capano has mentioned, are we really reaching to everybody per se? Should we expand further? And interestingly, we brought a third question, which is, after all, how do patients end up in Western medicine or what we are calling traditional medicine? Do they really try something else? Do they go to alternative therapy before? Or do they come directly to Western medicine? Or do they give up on Western medicine because of cost or prohibition, or even because it doesn't work? They go to the alternative medicine. We have no sense at all about that. Even our colleagues in Africa, they'll tell you they don't have a sense about or understanding of that component per se. So those key questions were brought in, and we really all felt that we should get a better read on the whole situation. If anything, Microsoft reached us, and I kind of jokingly say, like I said, how were you able to reach out to 500 people in Africa to really answer all those questions? And my answer was like, I know people. And if anything, to be fair, connectivity is very key. And that's really, you can see, thanks to all our colleagues in Africa, it was really robust teamwork. With the meeting that we did first time was, and still our meeting run in 2 languages to respectfully cover how medicine is taken care of in Africa in both English and French. And at the same time, we reach out every way we can to make sure that we'll be able to get what's necessary for that purpose. So that second part is now supported by 2 entities, Microsoft and AstraZeneca, with a third entity that's really more on the technical part called Avanade. But let me be very clear that the key players and key sponsors of that study, they created a screen inside the companies, i.e. the team that's working with us on that effort don't have anything, and they're shielded away from anything which is business part of the company, and vice versa. Nobody in the company will know about or shielded in regard to the information that we're getting. This is an academic work, but we felt without the experience and expertise of, for example, Microsoft will not be able to function per se. And to give them credit, they've been really robustly working with us for the last 2 years on a regular basis, every month meeting and working on where we are, what I'm going to show you what we're doing right now. So that actually, to give the credit, this is probably many of you might recall, this is data from, God bless his soul, Snorri Thorgarson, who was at the NCI. And at that time, if you recall, it was a rather basic approach, but an appropriate approach in regard to how do patients get liver cancer. And if anything, we know very well that they really can have an etiology. We know about Hep B, we have about Hep C, we talk about alcohol, and of course we talk about obesity at that time, but of course now we change it to NASH, and now we change it to MASH, metabolic associated hepatitis. And at that time, Snorri Thorgarson divided into certain genetic alterations. He thought, for example, that in the HBV, telomerase shortening might be a driver. Hep C, EGFR RAF kinase, alcohol, hypo and hypermethylation. Obesity, probably is a P53 driver. So there was an appropriate basic component, but it needed more. And that's really why we're doing the effort as well. Not only to enhance access, but also to understand whom are we treating them correctly. Because nowadays, we know very well that a lot of us are focusing on the cancer immunity cycle. We know very well that a lot of activity happened at the bottom of that cycle at point number 7, it got to the anti-PD-1, anti-PD-L1. But we know very well we need enhancers for that, among which point number 5, which shows anti-VEGF. At point number 3, we have the anti-CTLA-4. And of course, we have also add-on that are still being studied, like TIGIT, LAG-3, etc., etc. So, however, what does it mean for a specific population? What does it mean for patients who have a specific access to a certain therapy? What does it mean to certain risk factors that happen for this specific disease? For that, we really are realizing that, yes, people already are looking into this. This is the work of Dr. Pfister. You're all well aware of that paper from Nature, where we have found, exactly as I mentioned a little bit earlier, Hep B might fare a little bit more and do better in regard to the treatment with checkpoint inhibitors, followed by Hep C, followed by non-viral. To be fair, we sometimes overread that data because, number one, everybody benefits from the checkpoint inhibitors. But if anything, we know very well that some of them might need a little bit more kind of, will benefit more simply because of the etiology, but does not mean the others will not. And the question is along that line, why? And this is what nicely was described by actually David Pfister, and it's related to work by Dr. Chen that shows actually all, after all, this all related to some CD8 T cells that are called exhausted T cells that might, and to be fair, even in the Nature paper, Pfister and colleagues said, we are not sure exactly what the process is, but there's some kind of component that at least is inviting us. We need to dissect way more than what Snorri Ghassan has done in regard to etiology. We need to dissect a little bit further. So the effort that we're doing at the moment is really built on that map. We're going to look at many variables, and among which some of the signatures are here. They are not necessarily a perfect collection of all what's necessary, but to start with, we'll look at CD4, CD8, FOXP3, myeloid cells, CTLA4, Ki67, PD1, PDL1, of course, have BHC, and we're ready to do more. And the way we're doing it is making sure that we analyze data from all over the world, from different cohorts, and probably we have already cohorts from many parts of the world. We have one from Korea, we have one from India, we have one from Hawaii and the Pacific Islands, we have one from France, and we're collecting further. And the idea is, can we tell who gets what, should get what in regard to therapy because of the whole immune microenvironment that really is built up that will enhance or not enhance the use of certain specific checkpoint inhibitor. And of course, Africa, we owe the same example, even though we understand a little bit more complexity, which I'm going to touch about that in a second. But nonetheless, yes, our aim also to understand the genetic makeup of the tumor as well. So we're going to do that. If anything, we do recognize, and that's really the important component I'm going to bring up over here, we do recognize that after all, that Africa has a challenged GDP. And as you can see over here, the decision, by the way, of if a country is upper, low, middle income, it's really, by the way, I don't know if you know that, but it's actually self-described. And it be decided on like, what's needed for the economy. I.e., for example, if let's say you are short of a certain product, and you feel like probably if I lower my economy to what I call middle income rather than high income, or from middle income to low income, I might get further support or a better pricing, I can do that. And actually, people are permitted, countries are permitted to do that. And that's why you can see that the World Bank has this description, the UN has this description, and the World Trade Organization has this description as well. But these are all mainly decided by the countries themselves, except for one of them, which is the one you see at the bottom, which is the least developed country, or the LDCs. This decision that really made by the UN and cannot be touched on. No country can decide themselves to be an LDC or not. It's actually based on certain component, mainly regard to the assets of nutrition, health, education, and literacy. And those vulnerabilities, of course, will include the population size and the remoteness of population. And to that matter, very important fact, there are 48 LDCs in the whole world. To exemplify to you, the only country in all of Americas, the two Americas that's actually LDC, is Haiti. On the other hand, of the 48 LDC countries, 34 are in Africa. You can imagine how much this is really is a sounding and piercing information that's really important to recognize how much really we have and obligated to do for Africa as we continue to enhance. Why is that important? Because if you ask economically, and here you'll notice that I'm kind of like changing hats very quickly. I'm using my MBA, I'm using my JD here. But interestingly, if you really want to invest into any new development in the economy, guess where you're going to go? Where's the newest market? Africa. Young population, enthusiastic, ready to go, and definitely things are moving in the right direction. And any of us have been to Africa have seen over the years how improvement things are and are still ongoing per se. For that, we feel that obligation to do that. And for this reason, we are kind of like putting that kind of, the important review in regard to how to do this. As you can imagine, and I'm going to give a little bit of a scenario here. Let's assume, and I'll play my hypo as if it's me, even though proudly, and I'm very proud that we don't do that. If anything, I have currently a certain concept, as I just showed you one of them in regard to the genetic immune microenvironment of the tumor. I like to study that on my microscope and my lab. I call my friend Joe in Africa. Hey, Joe, we need to do this effort together. let's you ship the information to me and I'll pay the DHL, FedEx, whatever it is. I receive it by mail. I do the workup. We publish on it. And guess what? We have a publication. Joe is co-author. We're proud of the effort. And guess where all of this has gone? When we discover a drug, it went through the window because Africa will get nothing out of this effort. On the other hand, the vision review, and to give credit, I know Satish was involved in that when we were together at the White House back in July. We do the same, but this time, if there is a certain support for that effort, we're going to talk to that sponsor, say, by the way, you want that tissue from Africa? You want us to study it? And by the way, it's not as only Africa. We're giving Africa as an example here because we're talking about Africa. It could be anywhere else in the world. And if anything, we're ready to do that. But guess what? It's going to cost. And the cost is because ultimately we're going to calculate what will be beneficial for the patients in Africa. And the argument we're doing is that the tissue material and the samples of patients in Africa are probably way more expensive than all the diamonds that are in Africa. For that, that sponsor is going to pay upfront. They will ship the samples, we'll get the analysis, we'll publish, but more importantly, we're going to save that money. We're going to put it like in an escrow account, and then instead of having everything fly through the window, we're going to make it paid back to Africa in drugs that the benefit for the patient will benefit from. Interestingly, we already are in an official discussion about those concepts. Proudly, through my training as a lawyer, I was able to reach out to many of the country's other regulators or at the same time ministries. And we know that are seeing a certain openness to components of discussion of that nature. And I can at least name, not necessarily these are not to pin down countries, simply this is because of whom I had a chance to. We spoke with the Deputy AG of Ghana. We spoke with the Deputy Minister of Health in Cameroon. We spoke with the Minister of Health in Tanzania. And of course, we're happy to talk to everybody else. And Ashraf Omar on his part spoke with the Ministry of Health in Egypt as well. So where we go from there? So now that you know the concept, we really have a challenge. Would like to fine-tune it further. We continue to have a committee that we're very proud of. You can see that we're now trying to build in the information, not only to say, yes, now we know what the effects are and cry over it. Absolutely not. We're trying to find the business and legal model that will provide the patient care that they need in Africa. For this, where are we going or what are we doing? So I literally made sure that number one, as you saw it already, the first manuscript from the first effort is already in print. And number two is we're discussing all what we're working on with different societies, with the NCI, Central Global Health, and Satish is well aware of the information that we do, Dr. Gopal. With NCCN, we're talking with the WHO, we just talking with the American Cancer Society, ASCO is involved, everybody's involved. And here we go to the effort that we're doing with Microsoft and AstraZeneca and Avanade that is being done on the Microsoft platform. How are we doing it? We actually are making sure that we keep reaching to people. In September, I was in Dar es Salaam in Tanzania, and then they discussed all about the concept per se. Then after that, went to Dakar in Senegal, and we spoke at aortic, and we invited people to start doing discussion about this in November. Then after that, in Cape Town in May, we brought in, and now we announced officially that the information, the new study is gonna start on. And if anything, here we go. We met in Mombasa not that long ago, barely 3 weeks ago. And probably these are the four of us, you know, and recognize some of us, Lewis Roberts from Mayo, of course, also Ipa Jong from Sid Sana and Ashraf Omar from Cairo. This was the first time ever we meet in person all together because we were the writing committee for that paper, and it was a great delight. At that meeting, the AHPBCC, we announced and we declared the initiation of that new visit, and we did an exercise for everybody online right on the spot. We asked everybody, and this is how simple it's going to be. We asked them to either take a picture of the QR code that's right there. And by the way, if any of you would like to play with this now, it's totally fine. As you can just take your camera QR code, and it's going to prop you right away. You'll be in the study from Memorial. You just click the buttons, you answer what you have to answer, and you move on. And we have it as a link as well for anybody who really is using it on the computer. And if anything, the question is going to be literally registration. Who are you? Same as we did in the first study. However, we're going to go bottom line to even the city and see where exactly people are coming from. We're going to look into the traditional medicine component in regard to the different specialties. We'll look into how many patients are seen. We'll look into the screening methodology. We'll look into the vaccination and screening, the universal precautions. We'll look into the methodology for the diagnosis confirmation. We'll also go into the staging system that's being used. We'll look into what screening and methodology is being used or what kind of guidelines are being dependent on. We'll also look into the curative therapy, intermediate therapy, and also systemic therapy. And we added some patients, some questions. For example, here, based on what we learned from the first query, for example, we noticed, you remember I showed you like patients use a lot, physicians use a lot of systemic therapy in intermediate stage because they have no access for other things. We're asking more about it. Why? And we're trying to understand more about that as well. And we carry on, of course, to the what one you prefer regarding the intermediate stage, look into different choices of therapy. And of course, we added on more approved drugs as well, second line. And of course, in regard to Child-Pugh B and C, more advanced liver stage, what do you give therapy if you do any? And interestingly, we open also a different query for the patients who are really seeking alternative therapy approaches. Here, I give credit to our dear colleague from Cameroon, Dr. Christian Zuto, who came with the idea when we were doing the effort. And as such, we built in with his help and alternative therapy specialist from throughout the continent. And we're asking for the same thing, just here, we're asking for the same thing, doctrines, who are they? But at the same time, what kind of alternative therapy they do? We're reaching out to complementary medicine, integrative medicine, psychological medicine, spiritual medicine, herbal medicine, magical healers, spiritual healers, priests, magician, on and on. We want to make sure we read to everybody and understand from them, how do you access patients with liver cancer? What do you know about them? How do they get to you? And as such, we have question, how many do you see? Number two is, specifically, we'll ask about things that are more firm, definite answers like hepatitis vaccine. Do you describe it? Do you prescribe it to your patients? Number two is, how do you diagnose it? Let's learn. Let's see how they do in traditional medicine approaches in regard to diagnosis of liver cancer. We're going to look about, interestingly, do they come to the alternative medicine therapy first, or do they go to them after trying the traditional medicine therapy? And of course, do they refer patients to the traditional medicine therapy after they attempted the alternative medicine, or they see that maybe it's not really something I can help you with, you better go to do traditional medicine? As you can see, we're enhancing further a more in-depth understanding about like really who is who and what kind of access they are getting and what kind of access is available to them. And at the same time, when do they present them? After trying some or at presentation? And you notice, by the way, I'm sure you probably noticed that all the questions are made English-French. Everything is English-French. And to that matter, give credit. We already were acknowledged for that effort. As you know, many of us, Dr. Gopal was there. I was at the White House not that long ago, and we really brought in the effort that we're doing. We met with administrators, and the idea is this information hopefully will help us build up a better understanding of the disease worldwide and in Africa. For this, we're kind of like carrying on to that important recertification, rectification that we need for the tissue. I really stress it out intensely over here, and I repeat it one more time. Number two is, why this is important? Because who owns the tissue? And here, this, by the way, if any of you are used to this, but this, like, look at it, like this is almost like PubMed for a law student. So this from LexisNexis. And if anything, you can search anything. If you can put, for example, I want to look at any case of some dog-bitten index in the right hand, you can find it. And interestingly, this is a very famous paper, a very famous case that really is worth to learn from. If you recall, Moore had hairy cell leukemia, and Moore was treated in UCLA. And Moore actually required, in those days, there was no therapies for his leukemia. The treatment was to take spleen out. At that time, the spleen was taken out. It was preserved by UCLA investigators. It was kept. They continued to draw blood from Moore. And one day, if anything, they called and they said, oops, maybe we should have consented more for that. So they called, and his friend was there, and his friend is a lawyer, and said, wait a minute, they did not consent you for that. This became a case that went all the way to Supreme Court. And interestingly, this is really the message that we need to learn over here. The argument was, it's my spleen, it's mine. Why are you taking it from me? I did not consent you to it. And interestingly, maybe yes, there was an error in regard to the consent per se, but as you can imagine, more or any of us, we don't have like a special freezer for spleens. It's not like we know how to handle spleens at our homes. The court actually favored UCLA standing that this is important. And I love that word that was used in the case, is important for humanity. And in other words, that effort is really to be preserved for humanity. It doesn't mean that we're going to be lax and just do anything we want just because we feel like we're helping humanity. We have to do it right. And as such, consent is important. Acknowledging the effort that is done for the patients wherever they are, like as we said in Africa, make sure Africa is owed what's needed for the tissue that they're going to share with us for their research. We need to make sure that we do all of that right, to make sure that we do what's appropriate, what's ethical, and what's moral for our patients wherever they are. With this, I carry on to say, and this is nice work that I'm very proud of. I built in over the years with a lot of input about how we have to think global, but we have to act local. We have to reach out to our colleagues in Africa. We have to talk to them. We have to understand about their taste. How do they run things? How do they do it? What's technology available for them? What is the endowments in regard to enhancing that technology? What is the infrastructure, how they do that? And as you can see, we did a lot of those addressing per se. And the new thing that we're adding on, and they give credit here to one of our colleagues from the Eisenhower Institute, who I proudly took a course with about ESG, where we're looking now into the environmental, social, and governance components. So we make sure not we do it right only, but we also pass on to Africa and everywhere else in the world how to do it right, how to protect the rights of the patients and make sure we do it appropriately to get the right answers for the questions that we're bringing up. So for this, I wrap up by saying that the world, yes, we're doing in Africa, but probably we're doing a lot of work all over the world. Some of you know about that publication that we had, Larry Norton and I, in regard to using medical diplomacy as an effort to understand better about genetic and environmental variants. You can see here, we were able to reach out to many doctors all over the world. And proudly, and this is what we should be all very proud, doctors really stand always above the fray and do what's right, take care of patients. And as you can see here, and I'll pinpoint only certain parts of the world because really they pertain to what we're talking about. Remember all what's happening in Ukraine, Russia. We had Russian doctors, we have doctors from Belarus. On the other hand, in regard to the Middle East and the unfortunate situation that's happening in Israel, we had Israeli doctors. We had actually doctors from the Palestinian authorities being in Gaza or the West Bank. And proudly, they were all talking to each other. They were all trying to see how can we help each other for what's better for humanity. So with this, I'll stop and I'll pass it back to Dr. Gratin. Thank you very much for listening.
Wow. So that was amazing. I'm a little speechless here. So are there any questions? I'm sure there are plenty of questions. But I have one question which
by the way, you probably can increase, bring a little bit microphone, a little bit.
Sorry. No. Yeah, sorry. So what I was wondering is, I was very intrigued by your idea to actually, look for alternative medicine and include that whole branch. Can you tell us anything? Are you going to assess efficacy? I know it's very, very difficult, but I mean, we should also not ignore that. I actually mean it as in a positive way, to see that we can learn from them.
Yeah. Thanks so much, Dr. Gratin. So to be fair, no, we're not looking to efficacy at this point in time because we kind of, you notice we're highly focused on the access to care. But can we open opportunities by all means? Because already I alluded to it, and I think smartly you kind of caught on it because that's why the question is, can we learn something? Yeah. I remember I said the word learn from, can say, wait a minute, interestingly, maybe alternative medicine have a different approach that we can add on. Because after all, remember, we're not trying it by any shape or mean, trying to say, okay, we need to copycat what's happening in the Western Hemisphere, what's happening in, let's say, in Maryland or in New York or wherever it is, and redo it in Africa. Absolutely not. We're trying to see what are the assets, maybe certain novelty approaches that are being used, and can they be beneficial? Of course, then we'll adapt them part of those guidelines. Absolutely.
All right, who is next? Shin.
Oh, Ghassan, yeah, really impressive study. And obviously, that most of us would not have such, energy and the skill sets that you can initiate something like this. So this is really fantastic. Congratulations. So, you already say lots of wonderful stuff that really come out from those, but from those initiative. But by comparing with the outcome, I understand that the review article by Louis Roberts, and then you reference the different country with different survivalship. But we also know that the liver cancer is really heterogeneous. So by compare with different countries, literally it's not a population-based study. So it's possible to compare with apple and orange, right? So it's quite difficult because of heterogeneity. Now, your study probably going to be quite important because you can leverage all the region together. Now, you mentioned that many of the good lessons that you learned. I just want to challenge you to see if you could rank 3 biggest lessons you learned that if you're going to do the study again to avoid.
Yeah, thank you. No, thanks so much, Dr. Wang. So number one, I do acknowledge, and I totally agree with you, and I think Dr. Grattan asked the same question, which is like, can we, in one way or the other, really learn more from this? By all means, we can. It's a matter of like one step at a time. Remember, this is a very, as you said yourself, and by the way, any of us can do it, but this needs a lot of persistence. You need to be really very persistent with that because there are a lot of challenges that are going to come across the way. I mean, let me give you an example of this. And only I'm inserting that example, just tell you how much challenges you can find. So one of our colleagues who really is a co-author on the paper, he's from Burkina Faso, okay? And if anything, I literally wanted, JCO wanted from him a acknowledgement that he agreed to the copyrights and he has no conflict of interest. You know how difficult it was to make him find a place where he can print this, sign it, and fax it back? It was next to impossible. I had to wait for him until he flies to France for a meeting. And then he was on the train. He asked another passenger next to him. He told him, can I borrow your camera phone to take a picture of this and then try to send it through your email to be able to get it? That's really, and I give credit, JCO was beyond patient with us, and literally we went out of our way. I really tracked everybody. And interestingly, one of our colleagues at some point said, well, you know what, those doctors are not able to sign all that paperwork. Let's move on. I said, absolutely not. I really insisted that not a single person, but should be a co-author on the paper, because that really will say that we're very genuine about what we're doing. So these are challenges. For sure, they're going to happen. With this said, one step at a time. We're going to cross one thing at the other. So now, what are the things that we could learn better? Exactly. So the 3 things we could do more. Number one is, I think we have a misperception about the continent. Remember, we say Africa. I can't tell you how varied Africa is. And even interestingly, varied within Africa itself. For example, our colleague from Mozambique told us that if she has a patient in the capital, you know how easy it is to fly to Barcelona, to Portugal, to Lisbon, because they are, Portuguese speaking. They'll go to Lisbon, get the therapy. Of course they can. But anybody who's really from remote can't. And if anything, we knew that we have to learn how to access only to not the feel good, the physician whom we are able to talk to because they have access to us and we have access to them. We have to really go further than that. So we're doing our effort to really now, even some of our colleagues are promising us they're going to go into remote areas, meet doctors whom they never met before, and try to really bring in about this information as well. Point number 2, that really we feel that we don't really have appreciation of exactly in Africa specifically, why do patients get liver cancer? Because no doubt that yes, Hep B, Hep C, and MASH, but remember, the iron deposits in patients have a lot of big problem. And also the aspergillus in Africa is a big problem. And actually, even myself, I was actually one time in the days we could go, I was in Mali, and I literally saw the kind of casts where actually the huts where they collect the grains, and you can see the aspergillus like floating on all over it. So no doubt we have to be a little bit more open to understanding that not necessarily only certain risk factors are there one way or the other. And the third thing we learned is know that this is not a pure medical effort per se. This is we have to really move a lot of hats in between. And the reason is because it will be a little bit kind of like very highly focused, but very narrow thinking if we think only medical questions. We have to really bring in the psychosocial, legal, medical, add to the business model that really will make us succeed. And that's where we're thinking also that can we now start to invite experience from other disciplines, being business discipline or legal discipline or psychosocial discipline that can help us in that? Of course, we should.
Thank you so much. I guess you have to learn to speak French, right?
Exactement.
All right, Cecilia is next. Cecilia Mona.
Yes. Thank you, Dr. Abou-Alfa. That was an excellent session on a very, very important topic, and I appreciate your time. I have a question, and as you're well saying, this is a sort of a step-by-step approach that needs to be done to improve the prognosis and the lives of patients with HCC in Africa. But I wanted to know from your personal opinion, and it's delineated in the JCO global article that you nicely published. But if you were to put most of your effort in one area to start off with, where would you start? Because in the beginning, maybe even before your paper, as you well said, a lot of us would have thought, well, hepatitis B vaccination, but it's actually not that bad, right? Would it still be in prevention? Would it be in early stage treatment, especially in East and Central Africa? Because from a public health perspective and from a policy perspective, although here in the United States, we're very sort of concentrated and give a lot of effort to systemic treatments, we know that from a public health perspective, it may not be the best benefit for expenditure, basically. So I'm just wondering your personal opinion, understanding that this is a step-by-step process, where you would start if you had a significant amount of funding.
Yeah. No, great seeing you, by the way, Celia. Thanks so much for the question, and so nice to see you as well. So I do go back to what Shin has said, which is, if anything, yes, it needs a lot of energy. And if anything, I would not really say I'm going to focus only on one thing. All what you just mentioned, we have to do. Because to be fair, what I learned along the way, if let's say let's focus only on prevention. Somebody's gonna raise their hand. Wait a minute. I have stage 4 disease. What are you gonna do with me? I'm like, forgotten? Or the other way around. Like if you say, like, wait a minute, I am going to only focus on the stage 4 disease, but I have only disease that's really limited to the liver itself. What shall I do with that? So I think we have to really do it all at the same time. However, this is not a one-man show or one-person show. It's got to be all of us together. And in other words, I would not really try to celebrate one versus the other. I don't think we can say comfortably, now it's time for us to do prevention and screening as if like we cured everybody else. No, not really. And for that reason, we have to do it all at the same time and try to make sure whenever we can get an opportunity, grab on it and try to carry on with that. And to that matter, by the way, we're talking a little bit in a vertical direction, but believe it or not, we're also working in a horizontal direction. If anything, the same exact effort that we're doing, we're repeating it again in the Pacific Islands, because there's so much HCC in the Pacific Islands, and we're really trying to build the base from the New Zealand colleagues because of the Maoris and all the hepatitis B that they have, and try to really kind of, carry on to that effort to understand better their access to care, prevention, etc. So we're not really leaving it to one space or one area or one geography per se.
Thank you.
Sure.
All right, so we have 2 more questions. One is in the chat, is regarding the role of aflatoxin. If there's anything that you can say about this, if you were able to find or say something about it.
Yeah, of course. Thanks so much. I think it's Geraldina. Yeah,
Yes.
Absolutely. It's correct. I gave also already, I just quoted a personal experience. I've seen like really that, yes, it is real and it does still exist, especially you can see most of it happening in West Africa. And if anything, by all means, it causes liver cancer. Appreciation of it is not necessarily fully there, because as you can imagine, this happened mainly in remote villages and remote areas far away from the industrial cities. But is it really to analyze, understand better, and make sure that we educate about the prevention component, add to treatment component for it, even understand the immune microenvironment in aflatoxin-induced hepatocellular carcinoma? Of course we should.
And then the last question is coming from Joya Washika about the role of pharmaceutical companies. So she's asking, that in some of the South Africa, so for instance, South Africa, government-funded healthcare and reasonable GDP, the question is, what is actually the role of the companies in ongoing limited access to systemic treatment?
That's a great point. Joy, I 100% agree with you. We have to pose that question. We have to probe it and we have to look into it. And for that reason, we are contributing to the effort by explaining to the companies, and they know, remember, these are really robust companies, and we know very well how capable they are of to do good things. And please, everybody, as I'm saying that statement, these are all positive statements, because after all, they are colleagues and we're working with them. And if anything, we do understand that they really look always for potential markets. Because remember, drug companies have only one obligation. They want to report to their stockholders. But at the same time, they do good stuff as they go with that. And there's nothing wrong with this. And if anything, we have to make sure that always we bring the awareness for them, for the excitement for them. And as such, I would say that always, whenever we have the opportunity, we have to bring any of those concepts in regard to any presentation, in regard to any discussion, so they can really recognize that even the experts, the scientists that they are really dependent on for that research, are aware of this. As you noticed, and probably Dr. Grattan more than anybody else, because we go to the same meeting more or less here and there, I actually, the first time I brought this up was actually at ESMO in France about maybe 3 years ago. And I raised the hand and I said the question, what about all what you talk about, but the fact that really the access to care in Africa specific, and to be fair, everybody was mute. Nobody even said the statement. Not for any reason. I'm not saying that they don't care. Absolutely, everybody care. But to be fair, we're not trained yet to answer these things. And that's why we have to empower ourselves to be ready to answer and say this. To give credit, and I'm not, again, promoting any company over here, but to give credit, the CEO of AstraZeneca asked for a personal meeting with me, and he said specifically that definitely will listen to you and we'll see what we can do. And please keep us posted about the effort in Africa, because this is the way we can do more work per se. And I'm sure the other companies can do the same thing. I don't think there's going to be one company or the other. But yes, we have to bring this up. We have to bring it from that perspective, and we have to encourage them to think about it all the time.
All right, Ghassan, it's 2:02. I think, this was for me, it certainly was a highlight. It was very different from what we usually hear. I think it's probably more important than what we usually hear, but that's my personal opinion. And, thank you so much. It was great to have you present your work. Thanks so much.
It's all important. I'm proud to be part, but it's all important. But thanks again for all of you for listening in, and I'll carry on with the other meeting with many of you. Thank you very much. Thanks for having me. Thank you. Thanks.